Okay, so last time we left off, we were discussing bright blood imaging, the steady state free precession sequences. GE calls them Fiesta. These use fully refocused gradients. We'll talk about what that means in a few minutes. And that allows more signal to be preserved than conventional gradient echo sequences that are usually used in body imaging. And what's different about these bright blood cine sequences is that the contrast depends on the T2 to T1 ratio of the tissue, which means that the blood and fluid will be bright on these sequences. And then they'll tend to be darker on the gradient echo sequences used for body imaging. So this provides very good contrast between the blood pool and the myocardium for bright blood imaging. So these balanced gradient echo sequences, the TRs are very fast. So that means that there can be some transverse magnetization left over between one excitation pulse and the next excitation pulse. And to preserve as much signal between excitation pulses is that whatever gradients are applied during the imaging sequence to obtain spatial information, those are all reversed. Those are all balanced to maintain that phase coherence between excitation pulses. So what does all that fancy language means? It means that these are higher, these are richer in signal, especially for the blood pool. So the unbalanced sequences, these are what you use as gradient echo sequences in body imaging. Here, transverse coherence is somewhat disrupted between excitation pulses, so that it's not as signal rich as balanced gradient echo sequences, and you can see the difference here. A pulse sequence that's often used in body imaging is SPGR. What does the SP mean? What does that mean? If they say you're doing body imaging, you say, well, this is SPGR. What's the other name for that? SPGR? Spoiled grass. You guys heard of that? No. Okay, you don't spend enough time in body MR. Okay. So
we're in plenty of body MRI. They never call it that. Really?
Okay, so this is the GE term. So spoiled grass, what's done there is actually they disrupt the transverse coherence between the excitation pulses so that signal doesn't bleed from one excitation pulse to the other. The advantage of that is that it makes it more of a T1 weighted sequence. So that gradient echo imaging, especially spoiled grass, if you're doing body imaging, can be more of a T1 weighted sequence. But when we're doing cardiac MR, we use balanced gradient echo sequences, which is why the fluid will be brighter. Look at the pericardial effusion here. So if you're doing body imaging, it might look like that. But if you're doing cardiac imaging, because of the more balanced sequence, it'll look like this. So the bottom line is pericardial fluid is brighter, blood is brighter on the sequences that we use for cardiac imaging. And so here's a comparison. The balanced gradient echo sequences versus conventional gradient echo sequences. The TRs, we use very short TRs, very short TEs. Fluid is going to be very bright. You see pericardial effusion is brighter here. So we use faster gradients, better contrast, and fluid is bright. Okay, so that's what you have to know about these cine gradient echo sequences that we use for cardiac imaging. Okay, now let's talk about something a little different. Phase contrast imaging. What does this mean? So far, when we're looking at images, we're looking at the anatomy, right? So these are called magnitude images. So what does that mean, magnitude image? It means that the brightness of the pixels that you see here, or the voxels, the brightness that is represented here on the image has to do with the length of the vector here in the transverse plane. So the more signal there is in the transverse plane, which is really the length of that vector when you apply that 90-degree pulse and whatever pulse you apply and flipping it to the transverse plane, the longer this vector is, the more signal we will display in the image. So the brightness of each voxel has to do with the magnitude of the vector. So these are called magnitude images. It's the magnitude of the transverse component that determines the brightness of the pixel on the image, right? So far, that is all that we've talked about when we're talking about MRI. But there is also a phase component So you flipped it into the transverse plane, right? And this vector is rotating around. So there's also a phase component of this, which you can also measure, right? If you have enough imaging coils, you can measure not only the magnitude of this vector, but at any particular moment in time, what is the phase of this vector? Exactly where is it in the transverse plane as it's rotating around? So that's phase, right? So these vectors have magnitude and phase. Both of these can be measured with MR. So far, we've just talked about the magnitude. You know, how long is that vector, which is the signal here that is displayed, okay? So what do we mean by phase contrast? So assuming that, you know, we can also measure the phase, what happens here? So let's say we have a patient lying in the magnet, and you have a blood vessel here running along the long axis of the patient, okay? For any particular slice location, right, assume you do nothing, right? You just apply, or we just apply this gradient here that's going from low to high in that direction. For any particular slice location, any stationary tissue will be in phase with each other because the speed with which it precesses, or the phase, has to do with what's the strength of the magnetic field, right? The higher the magnetic field, the faster it will precess. The lower the magnetic field, the slower it will precess, right? So if we do nothing, if we just apply a gradient from here low to high, within that one axial plane, stationary tissue will be in phase with each other. But over a particular period of time, if you have flowing blood, this flowing blood is from outside of this imaging slice flowing into the imaging slice. Within any given period of time, as that blood is gone over this gradient, it is experiencing different strengths of the magnetic field by the time it gets into the imaging slice. So what that means is that this flowing blood will be somewhat out of phase with the stationary tissue within the imaging slice. It turns out that how much out of phase it is has to do with how rapidly it's moving. And so that phase component, how much out of phase it is with the stationary tissue, that can be measured. And the degree of out of phaseness is related to the velocity of the blood flow. So the blood has a phase memory, if you apply the sequence correctly, having to do with how much of this gradient it has gone through within a given interval of time. And that can be measured. So here, it's kind of depicted this way. If there are these bipolar gradients that are applied, and that's going to affect, how it goes out of phase. But don't worry about that so much. Just look at this image, right? So as we apply these gradients for the stationary spin, the gradients are applied in such a way that at the end of it, the stationary tissue, you'll see it starts to go out of phase, but then by the end, it is back to where it was in the beginning. So this stationary tissue, think of it as going all along the length of the patient here, okay? So that stationary tissue, by the time we've turned on the gradients and turned off the gradients, that stationary tissue goes back to where it started. So all the stationary tissue is in phase with itself. But this blood that is moving, because it is experiencing different strengths of this gradient as it is moving from here to here, winds up out of phase with the stationary tissue. And it is that out of phaseness of the moving blood that is what we're going to measure. And it turns out that the degree to which it is out of phase is related to how fast it is moving. And so the phase shift can be anywhere between plus 180 degrees to minus 180 degrees, depending on which way the blood is moving. So let's say if it's moving in this direction, you can measure phase shifts of up to plus 180 degrees, but if it's moving in the other direction, you can measure phase shifts up to negative 180 degrees, okay? But the point is that by measuring the phase shift anything by using the proper imaging sequence, anything that is phase shifted relative to the other tissue means that it is moving. And we can measure how much out of phase it is, okay? So far we've looked at the magnitude images, right, which is depiction of the anatomy. But if we take that phase information and pictorially display it, we get a phase image. And what does this phase image mean? The stationary protons, no color, right? So we'll depict it in such a way that stationary tissue is not going to be depicted as signal. It's depicted as noise. But for moving protons, spins that are moving, we can depict it as black or white, depending on which way it is moving. Right? So which way is it moving here? Moving? Well, it's the ascending aorta, so it's moving up cranially, right? Yeah. And then here, it's moving in the opposite direction. That's the descending aorta. It is moving towards the feet. So in this case, motion that is going up is depicted as black. Motion that is going down is depicted as white. Notice the main pulmonary artery here will be going up, right? It's going to be going up towards the patient's head. So that is depicted as black. The degree, the blackness and the whiteness of the image has to do with how fast it's moving. So here, the faster it's moving up, the more black it will be depicted. The faster it's moving down, the more white it will be depicted. So you'll notice that the velocity in the pulmonary artery is not as dark as the ascending aorta, because the velocity here is less than the velocity in the ascending aorta, okay? So this gives us a pictorial display of the direction of motion and the velocity of the motion. These are called phase images. So it turns out that you can quantitatively measure to come up with an average velocity of the ascending aorta or the descending aorta. And if you know the area of the vessel, the average velocity times the area of the vessel gives you the volume of blood flow within any period of time. So the volume of blood flow going through a vessel can be measured using phase contrast imaging. So the stationary protons, no color. Moving protons, black or white, depending on the direction of motion. The color depicts the flow direction and the velocity. This is analogous to color Doppler ultrasound. All right? So if you're familiar with color Doppler ultrasound, this is the equivalent on MR, where we're looking at motion and how the particular color has to do with the direction of motion, and the brightness of that color has to do with the velocity of the motion, okay? So if we're looking at the ascending aorta, notice the aorta changes color here during the cardiac cycle. Here it's going up, and then there it's black, which means the flow is going down. This is a person with aortic regurgitation. So we can plot this out over the whole cardiac cycle. We can calculate the amount of forward flow. We can calculate the amount of reverse flow. So this gives us a way of quantifying how much aortic regurgitation this patient has. So here are the magnitude images, here are the phase images. So we use the magnitude images for anatomy, we use the phase images here to actually calculate the amount of blood flow. So we can calculate the amount of forward flow, we can calculate the amount of reverse flow, we can quantify how severe is the aortic regurgitation in this patient using phase contrast MRI, okay? All right, so this we've gone through already, but remember I said that this pulse sequence will measure phase shifts of up to 180 degrees, either positive or negative, depending on which way the blood is flowing. Well, what happens if the phase shift is greater than 180 degrees? What does that mean? What's going to happen?
Does that mean you have to decrease the gradient?
The opposite. Right. It means that the blood is flowing too quickly and it's going to be mismapped. So remember, if a phase shift of minus 90 is the same as a phase shift of positive 270, right? So if the phase shift is positive 270 degrees, that will be interpreted as minus 90, which means that the flow direction will be interpreted incorrectly. Okay? If the blood is going too quickly, right, You can think of this is aliasing. If the blood is going too quickly, you're not going to be able to map it properly to what direction it's going, which means to correct for that, you have to increase the gradient that you're using. So the term for that is increasing the velocity encoding gradient. What's analogous to that in color Doppler? What do you do in Doppler if you get aliasing? What do you change? Who's taking the
Pulse repetition.
the PRF? You increase the pulse repetition frequency. So the PRF in color Doppler is analogous to the velocity encoding gradient here. How large are these gradients that you're going to use? So you have to have some idea of what you expect the peak velocity to be so that you pick the velocity encoding gradient properly. So here's an example. So here where the velocity encoding gradient was 100 centimeters per second. So, and this is in your protocol. Before you do your phase contrast sequence, you set what the velocity encoding gradient is going to be. Here it is set at 100 centimeters per second, which means that if the blood flow is higher than 100 centimeters per second, it will be mismapped. So here in the ascending aorta, notice that this portion of it, which should be black, because all of it should be going in the same direction, is depicted as white. So that has been mismapped as blood flow going in the wrong direction because of aliasing. So how do we fix that? Well, that means that the blood flow here is higher than 100 centimeters per second. We need to increase our velocity encoding gradient higher than that. So here when we increase it to 120, now the whole ascending aorta is black. Now we don't have any aliasing, so now we've selected it properly. So it's analogous to the pulse repetition frequency in Doppler. What does this mean? This means that after you do this, after you run the imaging sequence, if you're doing phase contrast imaging, you have to look at the images and make sure there's no aliasing to make sure that you've acquired your information correctly. So here's an example. So here we're looking at the main pulmonary artery, okay? Now the first thing we notice is that it's changing color here, right? So notice it's black, and then it changes to white, right? What does that mean?
Rigor.
Yeah, it means, so this patient has pulmonic regurg, right? But there's another thing that we also notice is that right here, remember, in the center of the vessel is where you have the highest velocity blood flow. Right here in the center of the vessel, when the whole vessel should be black, you see those flashes of white right in the center, okay? That's aliasing. That means that the blood flow here in the center is higher than what you have set the velocity encoding gradient at. So your velocity encoding gradient here is too low. You're getting aliasing here in the middle of the vessel during systole. So what do? We increase the velocity encoding gradient. Now we can still depict the pulmonary regurgitation. It's still changing color, but the aliasing has gone away because now our velocity encoding gradient is set higher to what it was when we did it, the first imaging sequence here. So now when we take measurements of the blood flow within the vessel, now they will be accurate. Here they're not going to be accurate because the flow in the center of the vessel has been mismapped. Okay? So we can do that. So here we can measure, for this patient with pulmonary regurgitation, we can measure the forward flow throughout the cardiac cycle. We can measure the reverse flow throughout the cardiac cycle. So we can now accurately quantify the amount of pulmonary regurgitation in this patient. So these are the magnitude images. These are the phase images. Stationary protons on your phase images, no color. Moving protons, black or white, depending on the velocity, depending on the direction, up or down. And you can change that. I mean, you can make up white, you can make up black. It just depends on, how you decide to set it. The color depicts the flow direction and the velocity. It's analogous to Doppler ultrasound. Okay? So we can take aortic flow measurements. Now, what you want to be, so if we're doing this on these two-dimensional images, here, okay, you want to make sure you're perpendicular to the vessel in all planes so that you get accurate flow information. So you want the vessel basically to look round, right? You want the vessel to look round when you're doing this in the plane cross-section to the vessel. So here, we're looking at the ascending aorta, so we set our imaging plane based on, our other sequences so that we're at cross-section to the vessel, so that the vessel now is nice and round. So when we do our phase contrast imaging, the vessel is round, and now our velocities will be accurate when we measure them. Remember, the cross-sectional area times the average velocity of blood flow is the flow rate. So we can calculate the flow rate within the ascending aorta here in this example. In this particular example here, okay, this patient has aortic regurg. See, it's changing color. So we can calculate the forward flow, we can calculate the reverse flow. Right? Notice how dilated the aorta is here. It's dilated, and here make sure that you're perpendicular to the anatomic direction of the vessel, so the vessel looks nice and round when you're doing these two-dimensional phase contrast images. So here, the reverse flow is calculated as minus 31 milliliters per heartbeat. So that's how much aortic regurgitation this person has. Now, in this example, if you look at the phase contrast image, you see that there's the different color in the center. Well, that means there's aliasing, and diagrammatically it's showing you that the phase shift was minus 270, but it's depicted as a positive 90 phase shift. That's why it's showing up as going in the wrong direction. Right? So your velocity encoding gradient, what do you have to do? You have to increase your velocity encoding gradient, go back and repeat the sequence so that your information is going to be more accurate. And you see here when you actually plot out the velocities, you see here that this one shows up in the wrong direction, right? It shows up down here because of aliasing, because your velocity encoding gradient was too low. So you have to go back and repeat it with a higher velocity encoding gradient. So here's another nice example. So here we have a patient who has mostly aortic stenosis. So here, when we look at our images, velocity encoding gradient at 200, look right in the center of the vessel. See that little tiny speckle of white? That's aliasing. All right? That means, well, we got to go back, we got to increase our velocity encoding gradient and repeat the experiment, make sure the aliasing goes away. Now our measurements will be accurate. So the question comes up, okay, so if you're measuring the velocity in ascending order, why don't we just set our velocity encoding gradient to 500 for everybody so that the aliasing never happens? Why don't we do that?
To decrease the accuracy?
Yes, yes, because there is an error in your measurement. So I don't know what the particular number is, but let's say it's plus or minus 10%. Plus or minus 10% of your velocity encoding gradient, right? So you're going to be increasing your error if your velocity encoding gradient is too high. So you want to make that velocity encoding gradient close to, but slightly above, the peak velocity that you expect to see within that vessel, okay? Okay, there we go. All right, so far, that's two-dimensional phase contrast imaging. There is also three-dimensional phase contrast imaging, which is really called 4D flow. So you know what the three dimensions are. The fourth dimension is time. Okay? So what they do here is they will apply the phase encoding gradient not just in that transverse plane when we're looking at the vessel in cross-section, but in all three dimensions. So you obtain these measurements in all three dimensions, so you actually get volumetric information about the flow. Regardless of the direction of the flow, you're imaging a whole volume, and you're imaging the direction of flow within that whole volume. So this is called 4D flow MRI. It takes longer to run these sequences. It can take 10 minutes to run the sequence. So you do there's a time penalty here. It takes a time, but you acquire the information over the whole volume, so that what you can do is you acquire the information, velocity encoding along all three directions. You acquire the information along all three volumes, and once you've acquired that information, you can go back to the volume and you can measure flow in any vessel wherever you want within your volume. So when we talked about the 2D phase contrast imaging that we were doing before, we're only looking at that vessel in one particular location. But here with 4D flow, you can look at anything that is within your imaging volume, and you can measure the direction and the velocities of flow anywhere within your imaging volume, regardless of what direction of flow it is. So you get images that look like this. Right? So this is 4D flow MR. So if you want to take a measurement here, you can take a measurement there. If you want to take a measurement here, you can take a measurement there. If you want to take a measurement here near the aortic root, you can take a measurement there. So you acquire all of this information, and then you can go back and you can take an infinite number of measurements wherever you want to calculate flow. Okay? So that's called 4D flow MR. So here's a nice example. It's a little bit of, and it's color coded here, right? So the color here is higher velocity. So here we're looking at the aorta. What problem does this person have? Yeah, there's coarctation. So you see there's a little bit of narrowing right there, and you can see that the velocity is higher, right? You see that red? So once you've acquired the information over the whole volume, wherever you see these lines, you can put these lines anywhere. You can take measurements anywhere you want within the vessel, okay? All right, one other thing to talk about. We talked about breathing motion when we're doing MR, when we're doing cardiac MR, right? And so the way we get rid of breathing motion is we ask the patient to hold their breath, right? But what if the patient can't hold their breath? What if there's a particular imaging sequence that you want to run that takes a large amount of time? So, you know, having the patient hold their breath is not practical. There are sequences called free breathing navigator acquisitions. So how does this work? Well, this works by finding the diaphragm. So we'll find, and the important thing is we're going to track the motion of the diaphragm, right? But where you track the motion of the diaphragm, because you're going to be introducing gradients and stuff to track the motion of the diaphragm, where you pick to track the motion of the diaphragm, you want to make sure that is away, pretty far away, or outside of any anatomy that you want to look at. So if we want to look at the heart, we will track the motion of the diaphragm away from the heart so that it doesn't affect, when we look at the heart then, the information that we're acquiring. So the diaphragm moves up and down as the patient breathes. So you can see here, this is tracking the motion of the diaphragm as it's moving up and down. And so we set the tracker away from the area of interest. And then what we will do is we will set this interval here. And whenever the diaphragm falls within that interval, so we're going to run the imaging sequence throughout the whole time course of this thing while the patient is breathing. But it's only when the diaphragm falls within that narrow range, that's the data we're going to use to reconstruct our images. Okay, so the diaphragm is going up and down, but only when it is in this narrow range, right, when it's in the same position in that narrow range, that's the information we're going to use for our images. So all of the rest of this information is going to be thrown away. Okay, that's why it's going to take a long time, right? So we're going to shoot first, have the patient breathe throughout the imaging sequence, track the diaphragm, pick the information where the diaphragm is within our window, and then that's the information that we use to generate our images. That's called free breathing navigator acquisitions. So these can be used for coronary artery imaging if you want to image the coronary arteries using MR. There are other sequences where you can use it also. But the problem is it takes a long time to run the sequence because there's so much information that you're throwing away here. And you're only keeping the information when the diaphragm is within this narrow window. Okay? Free breathing navigator acquisition. All right. So these are the imaging techniques that we've talked about, and I did give you an article to read. According to the article, that AJR article, this is an SSFP steady-state pre-precession sequence. So, is that correct? Well, it's nice to know that all of you read that article very diligently and carefully and examined all of the pictures accurately, but that's what the article said. Is this, so what is SSFP, steady state pre-precession? What do we use that for?
Dynamic bright spot imaging.
Yeah, it's dynamic bright field imaging, right? That's where you get our cardiac movies. Is this an SSFP3 sequence? What is this sequence?
I think it looks like a gradient echo.
Is that a gradient echo? You have what your RF
Spin
pulse?
echo.
It's a spin echo. You have a 90-degree pulse. You know, these questions come up on the exam. You have to be able to, you know, if they give you the pulse diagram, especially if it's a simple spin echo sequence, this is like MR 101 intro MR. You have to be able to recognize that. Right? So that's a conventional spin echo sequence. Okay? 90-degree pulse, 180-degree pulse signal, spin echo sequence. Right? We talked about that. That was the first thing we talked about. Okay? According to the article, this is an echoplanar sequence. Is that correct? No. What is this? Yeah, so this is a gradient echo sequence. So the alpha angle there is less than 90 degrees. But notice that, what's the other clue that this is not a spin echo? There's no 180-degree pulse, right? There's no 180-degree pulse. So how do they focus the signal to get a signal at this particular point in time, at this TE, right? How did they do that? There's no spin echo, so how do you get a signal here? What focused signal here? The read gradient. There was a dephasing read gradient, and then there's a rephasing deep gradient, and right at the peak of the rephasing deep read gradient is when you get your signal. So it uses the read gradient to focus. Actually, spin echo does that also, right? If you go back to your spin echo sequence, it does the same thing with the read gradients. There's a refocusing read gradient that has to be timed to when the 180-degree pulse would also focus your echoes, so that everything is nice and in phase at that particular moment in time. So in essence, even spin echo sequences are gradient echo sequences. But they will use both the 180-degree pulse and the read gradient to focus the signal at the particular TE that you've selected. But the gradient echo sequence does it without the 180-degree pulse. An echoplanar sequence, what is an echoplanar sequence? An echoplanar sequence, these are very rapid imaging. The echoplanar sequence, they will change the phase encode and the read encode ingredient at the same time and acquire all this information very quickly, so that these are very rapid imaging sequences. So this is used, these echoplanar imaging sequences are used for perfusion imaging. If we're doing cardiac MR, we will use these for perfusion imaging. These are very rapid sequences. So all of the data for one slice can be obtained after just one radio frequency pulse. So it acquires the information very rapidly. Used for MR perfusion. What's the downside?
Noisier.
Hmm?
Noisier.
Noise, right, it's very noisy. Remember, when you're doing CT, right, the penalty for better image quality in CT is what?
Dose.
Radiation dose. The penalty in MR for better image quality is time. Yeah, time. Okay. So if you're shortening the time interval to obtain your data, you're going to pay a noise penalty. So these images will be very noisy. Okay. All right. Now let's move on to what are the imaging planes that we use for cardiac imaging, right? We have long axis views, short axis views, and then we'll talk about some other views that we also use and how do we get these planes. Okay, remember, the heart is not like the brain, right? The brain falls nicely within the symmetric axes of the body. So if you take axial images of the brain, you have nice symmetry from one side to the other. Same thing when you take sagittal and coronal images, right? It's not true for the heart. So you need specialized imaging planes to look at the anatomy of the heart because it doesn't coincide, the anatomy of the chambers don't coincide with the natural axes, the natural symmetric axes of the body. Right? So intuitively, four-chamber view, four chambers, left atrium, left ventricle, right atrium, right ventricle. Two-chamber view, we see the left atrium and the left ventricle. So you can look at the mitral valve. Right? Left ventricular outflow tract view. In this view, we will see the inflow to the left ventricle. We will see the outflow of the left ventricle. Now I'm showing you echoes, which is what they also use in echocardiography. They'll use the same views that we use, or very close to the same views that we use in MR. So, it's not unusual for us to look at echocardiograms. And many of these patients have abnormal echoes, and that's why they're sent for MR. So if you know MR imaging, you can actually look at these echoes and get some anatomic information. And then the short axis views, these are always perpendicular to your long axis views. So in these short axis views, the left ventricle will be round. So the left ventricle will look like a donut. And so as the short axis views, we obtain a stack of short axis views, and this is what we will use to derive functional information from our short axis views. Okay? So that's what a four-chamber view looks like on MR. Left atrium, left ventricle, right atrium, right ventricle. This guy over here is mitral valve. This guy over here is tricuspid valve. Right, very easy to interpret. Two-chamber view. Right, this guy over here is, this guy over here is this left ventricle, right? This guy is mitral valve. What is this guy? That's the left atrial appendage, right? So on a good two-chamber view, you should catch the left atrial appendage, right? So that's a very nice two-chamber view here, okay? Left ventricular outflow tract view. So to get your left ventricular outflow tract view, essentially you're connecting 3 points. Remember, 3 points determine a plane. What are those 3 points that determine the plane of the left ventricular outflow tract view? What? The pulmonary vein. We're looking at the left ventricle, right? We don't care about the pulmonary vein if you're looking at the left ventricle. What are the 3 points that determine the plane for a left ventricular outflow tract view? Not the left. No, not the left. Not quite the left atrium. What specific point? Somebody said mitral valve. The midpoint of the mitral valve. So 1 point, the midpoint of the mitral valve. The second point, the apex of the left ventricle. The third point, the midpoint of the aortic valve. Those 3 points determine the plane of the left ventricular outflow tract view. Okay? So you can look at the inflow and the outflow from the left ventricle on the same image. And notice, what am I pointing to exactly here? What is that guy? That's the anterior leaflet of mitral valve. Notice it connects to the aortic valve. We talked about fibrous continuity for the morphology of the left ventricle. Okay. The short axis view, these are perpendicular to your long axis views. So here the left ventricle will appear round, okay? Right ventricle is somewhat more elliptical. And these are good for looking at wall motion, and these are good for quantifying cardiac function. We will look at this in systole and diastole. We can calculate cardiac outputs, ejection fractions from a stack of short axis views. So how do we start? How do we get this views from MR? Well, we start with a series of these axial localizers, really. We'll go through the entire chest, right? And these are basically the same things that we use. So we talked about the cardiac gated, the Cine Fiestas, those cardiac gated imaging sequences that we use for cardiac motion. It's the same sequence, only we run it without cardiac gating. So if you run this without cardiac gating, you can obtain a whole series of images very rapidly, right? So it's that same balanced gradient echo sequence, only we run it without cardiac gating. So you get the whole chest in axial images. And then we use these as localizers to find the heart, look at the aorta, pulmonary arteries. So these nice axial set of images. Also looks at the lungs, pleural effusion. Gives you a nice idea of what's going on right away from a series of axial images. So we'll start with these. Okay? Then we find the heart. And if the heart is sitting on top of the diaphragm relatively nicely, an axial image will almost look like a four-chamber view, right? You're used to this from CT, that sometimes your axial images on CT on CT look just like four-chamber views. That's because the heart is sitting nice and flat on top of the diaphragm. Well, if that's the case that we have, what we will do then is we will identify the midpoint of the mitral valve from those axial localizers that we have. We find the apex of the left ventricle, we just connect those two and we take a plane through there, right? So we'll run a plane through there, and then now we'll run a cardiac gated Cine gradient echo sequence here through that, and that gives us a nice approximation of a two-chamber view. May not be exact, but it's close. This is a pretty good, pretty decent two-chamber view. So we start from there. So now we have, excuse me one second. So now we have a two-chamber view here, okay? All right. From this two-chamber view, the next thing we will do is we will obtain short axis scouts. So we will take our two-chamber view, we will cut it in cross-section like this. So we will obtain a series of short axis scouts. These are not gated, which means that we can obtain these very rapidly. We're not going to be looking at motion here. These are just for localizing. So now we've obtained a series of short axis scouts going from the base of the ventricle to the apex of the ventricle. All right, so now we have some decent short axis scouts. Now what are we going to do? Well, if you take this particular short axis scout view, right? Here's the left ventricle, here's the right ventricle. We take the midpoint of the left ventricle and you run a plane from that through the apex of the right ventricle. That is a four-chamber view. So remember, as you're looking at this, think of the left atrium as being behind the board. Think of the right atrium as being behind the board. So if we take a view like this, now we're going to be cutting through the left ventricle, the right ventricle, the left atrium that's behind the board, and the right atrium that's behind the board, and that gives us a four-chamber view. Okay? So now we have a nice four-chamber view. Okay. Well, now if we go to the base of the heart on our short axis scouts, here's the aorta here, the base of the aorta, here's the midpoint of the ventricle. We take a line like this. This is called a light bulb view, by the way, because it kind of looks like a light bulb. So it's very easy for the technologist to identify. Just say, go to the light bulb image, right? That's this one. You take a plane like this, that gives you a nice left ventricular outflow tract view. Right? So here's a nice left ventricular outflow tract. And you get that from this short axis scout that we've gotten before. So here's our VOT, left ventricular outflow tract. Moving right along. Now, if we really want a good two-chamber view, we have a four-chamber view, we have our short axis scout here. Remember that a line like this will give you a two-chamber view, but we align that with our four-chamber view to make sure that we're going through the midpoint of the mitral valve, make sure we're going through the apex of the ventricle here, right? And when we do that, we get a pretty decent two-chamber view. Now we have a two-chamber view. Left atrium, left ventricle, left atrial appendage. Okay? So now we've got a nice two-chamber. So if you weren't happy with your first two-chamber view, you can go back and adjust it here. And try to get a better one. Okay. Now since we have a good four-chamber view, and now we have a good two-chamber view, now we can get really good short axis views. And these we're going to run with cardiac gating so that we can derive our functional information. So what we will do is we will line up our axes here so that we're perpendicular to the left ventricle on both the 2-chamber view and the 4-chamber view. So notice we will go through here the mitral valve plane on both views. So you try to connect here, like to connect the atrioventricular groove on the left with the atrioventricular groove on the right. Try to be perpendicular to the interventricular septum on your 4-chamber view. Make sure you're perpendicular to the left ventricle on your 2-chamber view, so you line these up, you prescribe these, and now you have very nice short axis views going from the base of the ventricle to the apex. Okay. And here's our 2-chamber views. Here's our short axis views going from the base to the apex of the ventricle. And then what we can do is, go back. So you can look at these in systole, you can look at these in diastole, you can measure the volume of the left ventricle in systole, you can measure the volume of the left ventricle in diastole. Of course, the difference tells you how much blood is being ejected from the left ventricle. You can do the same thing with the right ventricle. So you can calculate your cardiac output, you can calculate ejection fractions, and this is how you derive your functional information on a cardiac MR. So we can use our short axis views to evaluate myocardial contraction. You can look at wall motion. During systole, the myocardium should thicken. So you can calculate stroke volumes, you can calculate cardiac mass. So all of your functional calculations are usually done using these short axis views. Okay? Myocardial wall thickening, you can calculate how much does the myocardium thicken. Does it thicken normally? Right? So all of that you can do with your short axis views. Another view that is often useful, especially if there's pathology of the aortic valve, coronal ascending aorta. So from sagittal localizers, if you just drop a coronal plane like this that goes through the ascending aorta, you get a pretty nice coronal view from the left ventricle going into the ascending aorta. So here's a nice example of that. Right? So here's the left ventricle, here's the ascending aorta. You can see the sinuses of Valsalva here. What is this guy over here? That's the left main coronary artery. Right. What problem does this person have? Yeah, this person has aortic regurg. You can see how nicely it's demonstrated here on this coronal ascending aorta view. Right. So we can do that. Now, you can get from one view to other views if you just, if you just kind of internalize the way the heart is oriented and the way these chambers are laid out. So from a short axis view, if you take a cut like this, right, that will give you a 2-chamber view. From a short axis view, if you take a cut like this, that will give you a 4-chamber view. And we talked about at the base of the heart, from the light bulb view, if you take a cut like this, that gives you a 3-chamber view, also called a left ventricular outflow tract view. Okay? So from your short axis views, you can get to any of these other views. Now, just going through that quickly, so we started with our axial plane, got a nice kind of approximation of a 2-chamber view. From here, we got short axis scouts. Once we got our short axis scouts, we're able from there to, from this to get a 3-chamber view. We're able from the short axis scout to get a 4-chamber view. If we wanted to get a better 2-chamber view, we can go back and get a better 2-chamber view, and then we will take our 2-chamber view, we'll take our 4-chamber view and our 2-chamber view, we will use those to generate your short axis cine views. Okay? Now sometimes the heart is not lying flat along the diaphragm. Sometimes it's kind of lying like this, where it's taller than it is flat, right? So what can you do there? Well, there, if you take a cut like this from sagittal localizers going through the midpoint of the mitral valve to the apex of the left ventricle, that can give you an approximate 4-chamber view. And then from here, you can get short axis scouts, and then you're off and running back to the racetrack. Right, from your short axis scouts, we've talked about how you can get all your other views. Okay? So if you're just familiar with the anatomy of the heart, the way it's laid out, you can always, go back, manipulate this to get better views if there's any particular anatomy that you want to look at and you're not happy with the views that the technologist gave you. Okay? All right, so like I said, from diastole and systole, you can calculate end diastolic volumes and systolic volumes, stroke volumes, ejection fractions, all of this wonderful stuff we can get usually from our short axis views. Myocardial segments, there are names to these myocardial segments, right? So if there's pathology within a myocardial segment, okay, you can localize it to either the base, the mid-ventricle, or the apex. Is it the anterior segment, anteroseptal, inferoseptal? So when you're reporting cardiac MR, when you're localizing abnormalities, it's best to localize it to these particular segments, okay, so that you can tell the referring physician exactly where the abnormality is. And then they correspond to coronary artery territories also. So here's an example where the septum is not moving very nicely. So this person has a hypokinetic septum. And we talked about this example here. The light bulb view gives you a left ventricular outflow tract view. What's the problem for this patient? There's aortic regurg. Anything else?
Stenosis.
There's also stenosis, right? So this person has both aortic valvular stenosis and aortic valve regurgitation. Okay. Now, I talked about a left ventricular outflow tract view. There's also a right ventricular outflow tract view, if you want to look at the right ventricle. So the 3 points you would want to connect for a right ventricular outflow tract view, you connect the midpoint of the tricuspid valve, the midpoint of the pulmonic valve, and the apex of the right ventricle. If you connect those 3 points, you get a right ventricular outflow tract view. So the tricuspid valve would be here. Here's the apex of the ventricle. Pulmonic valve out here, so that's a right ventricular outflow tract view. Notice here, though, the inflow and the outflow are separated, right? Because the right ventricle morphology is different from the left ventricular morphology. There's the infundibulum, which is the outflow tract of the right ventricle. So there's separation of the inflow and the outflow valves for the right ventricle. So just like a left ventricular outflow tract view, if you wanted a right ventricular outflow tract view, you can get that also. You connect the midpoint of the tricuspid valve to the apex of the ventricle, and also the midpoint of the pulmonic valve. Those are the 3 points you connect for the plan of a right ventricular outflow tract view. Okay. Perfusion. So we can also look at myocardial perfusion with cardiac MR. So as I've said, these are very rapid imaging sequences, and this is done dynamically as the contrast. So this is speeded up. So this is done dynamically as the contrast is injected, and we will watch the enhancement of the myocardium, looking for perfusion defects of the myocardium. So here you'll see we're taking a particular slice look. This is breathing motion here. Okay, so it is cardiac gated, so you don't see much cardiac motion, but there is breathing motion. So we inject the contrast, and we take our images at particular slice locations. And you can see the contrast going into the right ventricle. Again, this is speeded up. Going into the right ventricle, going into the left ventricle, and you can see the enhancement, the myocardium enhancing here, right? So this is a normal first pass perfusion study. Now these can be used for looking for ischemia. So what is the idea here? It's the same as for nuclear medicine. If the patient has a stenotic lesion, a flow-limiting stenotic lesion, there is normally vasodilation of the coronary artery distal to that lesion to maintain the perfusion at rest, okay? So that if you look at a rest perfusion study, the perfusion of the ischemic myocardium will be the same as the perfusion of the normal myocardium because of this vasodilation. But when you stress the patient, then we increase the flow to the normal myocardium, but you're not able to increase the flow to the ischemic myocardium because of this flow-limiting lesion. So it is under the stress condition that you will see a perfusion defect. So this is called a reversible perfusion defect, right? Because it's not there at rest, but it is there at stress. So this is what you look for in nuclear medicine, and also for if you're doing perfusion studies with MR, if we're looking for ischemia. And then the stress, of course, with the patient's not exercising, right, in the magnet, so we use either dobutamine or adenosine or some other agents. So it's pharmacologic stress that is applied to the patient, right? So under the resting condition, normal perfusion, you don't see a defect. Under the stress condition, there is a perfusion defect that is a reversible defect here. So this person has ischemia within the course of what vessel? And here's the SPECT, the thallium study. LAD, right, so that's an LAD, so you would expect a tight lesion somewhere in the LAD distribution, okay? So here's a rest perfusion study. Here's a stress perfusion study. Again, no perfusion defect here. Here you see a perfusion defect affecting here the interventricular septum. Again, it's along the course of what vessel? Well, what vessel supplies the septum? The anterior septum. LAD, right. Along, again, it's along the course of the LAD. So those are perfusion defects. So perfusion, if you're doing a perfusion study, the right ventricle fills first, then the left ventricle fills, then healthy myocardium will enhance. And if you're doing stress, ischemic myocardium will enhance later. If there's an infarct, you will see a perfusion defect both in the stress condition and also in the resting condition, right? So if there's an infarct, in this case, you can see that there's a perfusion defect here. So that perfusion defect will be there in the stress and the resting condition. Also, there's another feature in this particular case that also tells you that this is an infarction. What's that feature? Well, what do you think of the thickness of the myocardium? It's atrophic. Right? So the myocardium is atrophic here, so that's a chronic infarct. Okay. So this is what we can see there. Okay. All right. So we'll stop here and we'll get to delayed enhancement next time.